Hi dentist, how are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday, and I think you get the habit. Every Sunday we have the weekly newsletter. We reached number 7, which make me really happy about that. I hope you get some benefit from those important questions and the concept around those questions. As usual, you will have the tags in the below bar where you can go to specific question, and the left side of the screen you can reach the previous newsletter where you can see the question and the discussion, and in the upper right side corner you can see the clip where you can push it and then you can download the PDF file. With that being said, let's not waste more time and let's start. First question from pharmacology: which of the following statement is false? I would really recommend you here to stop in your exam when you are practicing question to do this. When you read word false, you go and get your pencil and beside it make like cross mark. Or if you see a truth one or true, so you make check mark this way. Why? Because when you read the question and then you go to options and then you get deep to think about them, you might forgot. I'm looking for false or true. I know this may be sound for you. No, no, man, it's easy for me. But trust me, when you do this, it's easier for you to get the answer and save time. Diazepam has low lipid solubility. Diazepam has active metabolites. The action of diazepam may be reversed by flumanazole. Diazepam does not require adjustment in patients with chronic renal disease. So we speak about diazepam. So let's speak first about diazepam and the family it comes from. It comes from family called benzodiazepine. They are potent and effective drug for the management of acute seizures and status epilepticus. They have three main categories. Lorazepam, diazepam, clonazepam have been the most widely studied of benzodiazepine in the treatment of status epilepticus. And here come the chemical structure of this family. Okay, so all three benzodiazepine are lipid soluble and enter the brain within seconds to minutes after intravenous administration. And let's stop here for a few seconds. So we come to conclusion everyone in this family are lipid soluble and they can enter blood-brain barrier within minutes to seconds after intravenous administration. But diazepam is very lipid soluble and highly protein bound. And let's stop here. When we say very lipid soluble, so you can think it can enter brain fast, so it has fast onset of action, but it will have highly protein bound, meaning it has very large volume of distribution of unbound drug. Meaning when you give your patient intravenous diazepam, it will act fast, but the action will diminish very fast. Within 15-20 minutes, it will be gone. But as we can see here, it's highly protein bound, meaning there is large volume of diazepam you give to your patient, still bounded to albumin protein, for example. And then with time, this albumin will release this diazepam, benzodiazepam, to go inside your blood, so to give action more. So although it has very rapid onset of action, it will have very long duration of action. I hope this is clear for you because this is confusing for most of us. Like when you read it, like it has high lipid solubility, fast mode of action, so it will last for less time. No, it will last for a long time because of this part. As a result, the effectiveness duration of action of diazepam in status epilepticus is only 20 to 30 minutes, whereas that of lorazepam, which has much smaller volume of distribution of unbound drug, is at least several hours after a single intravenous injection. So you can come to conclusion the orderly administration of anti-epileptic drug for long-term seizure control after status epilepticus has been controlled. So we tend to use lorazepam is a preferable for the initial management of status epilepticus, but continuous intravenous infusion of diazepam has been used successfully in the management of some patients with status epilepticus refractory to initial treatment. So the drug we are going to use is diazepam. We are not going to use diazepam because, as we said, but we can use it for refractory patient if it's not working. But how does it work? The action that benzodiazepine is working is they go to GABA receptors. These GABA receptors inside your synapse. These GABA receptors is responsible of letting chlor to go inside your cells. And when this chlor go inside your cells, it go to a status of hyperpolarization, meaning if you are stimulated to any noxious stimulus like punching or pricking with a needle or anything, and you have this GABA active, very active because of benzodiazepine here. So more chlorine is going inside. So the action potential required for the signal to be fired inside your nerves is very high, meaning you will be in like deep, you can say sedation, you can say sleeping, you can say this medical term, but this is how it works. It go to the GABA receptors, facilitate the chlorine to go, facilitate the GABA to bind to these receptors. When the receptors is occupied with GABA, so it will lead to more chlorine coming inside, meaning you go into sedation. So they act by facilitating the binding of inhibitory neurostimulant, which is GABA, at various GABA receptors throughout the CNS. Because they have a lower tendency to cause a potentially fatal CNS depression compared to earlier drugs such as barbiturate, benzodiazepines are widely used in medicine for the treatment of anxiety as an anxiolytic, for the treating of insomnia, as hypnotic also, as well as other psychological conditions such as panic attack and panic disorder. So barbiturate is working the same mechanism, but benzodiazepine can be reversed by giving flumanazole. So if you give your patient flumanazole, it will act to kick diazepam out of this receptor. So your patient will go from his sedation. Maybe he's going to be over sedated, so he's in very bad situation because like he might get to respiratory depression, which might lead to his death. So we get to use antidote for this medication to kick it out. But for barbiturates, it has no antidote. So that's why they move from barbiturates to benzodiazepine. There is no clear division between anxiolytic and hypnotics. As we said, like it's very hard to differentiate between them. Since most anxiolytics will induce sleep if taken at night, and most hypnotics will sedate when taken during the day. So you cannot differentiate really between them. Okay? Let's give you a visual of how does it work. Think about this way. You are staying at your house, someone knock at your door, you open your door and you found this one trying to attack you. So you will be panicked. But if you did have take some diazepam, like maybe 20 minutes or 30 minutes before this, what the diazepam is going to do? Diazepam is going to facilitate the GABA to go inside the GABA receptors and get more chlorine to come inside this one, leading to hyperpolarization, which leading to inhibition of excitation. So you will be looking like this. You see someone at your door trying to attack you, but you are at the other status of you have inhibited the mechanism where you can get excited. So this one lost anticoagulant effect, anticonvulsant effect, and sedation and muscle relaxation because you did take this medication. So the medication is working this way. So when you take the benzodiazepine, it will go. This is a normal mechanism. So the GABA is going to this one to go inhibitory, so the signal will be less. When you have this one acting this way, but when you have the benzodiazepine working, it will lead to more chlorine coming inside, so it will lead the signal coming to your peripheral side is less. So meaning you have muscle relaxant, you have this all effect we have for this one. So, and this is very important for you to understand. As we said, there is 3 families. We speak about diazepam for half-life to be 20 to 80, although it's fast, because we say it's fast because it's high lipid solubility, but it has high half-life because it has large volume of distribution. It will be bounded to albumin and other protein inside your body, and it will be released. So it will have long onset, long action of duration. And you see here oxazepam on the other spectrum have half-life 5 to 10 and is slow action. And temazepam, clonazepam, it has maybe mix between fast and slow. But this one I would like you to understand because this is confusing how you think it's fast acting but long duration because of it's highly bounded to protein. So Valium is the mainstream used as diazepam. It will give you side effect as agitation, balance problem, blurred vision, constipation, depressed sex drive, drowsiness, nausea, and tired. You feel like tired all the time, okay? And if you're trying to get your patient out of this medication, he will have nausea, insomnia, grand mal seizure even. He will have some sensation in his body. He will have delirium, muscle spasm, anxiety, and depression. So that's why this group of family are very dangerous. It should be used under strict condition and for very short duration. So as we're looking for a false one, diazepam has low, no, diazepam has high liver solubility, has active metabolites, and this is one more feature of diazepam leading to it will have longer half-life. The action of diazepam can be reversed by flumazenal, and this is, we said before, it's competitive antagonist and does not require adjustment. No, it does acquire adjustment in chronic renal disease because it's mostly getting out or metabolized in liver and then getting out through the kidney. So we should look out for this one with elderly patient and patient with chronic renal disease. Second question from pharma. Which of the following is not a side effect of opioid administration? So again, not. So you make X here and then you read the options. Mydriasis, respiratory depression, constipation, nausea. And so opioids, as we said, it's never the first option for us to be used as analgesics for our patient because it leads to nausea, vomiting, constipation, itchiness, sleeplessness, slowed breathing, and impaired motor skills, thinking, or judgment. Because, as we all know, opioids are working centrally. They work in the MAO and GABA and receptors in your brain, leading to less action. So you're feeling the pain, but your brain cannot translate the pain because the threshold here is very high. So your brain cannot think about this. Your brain cannot deal with it. So this has package of side effect, including this one. But for you, it's hard to memorize everything, so I give you this mnemonic where you can try to memorize everything. And it starts with morphine. So M for meiosis, because like when you're having this medication, you tend to stay at home. So think about it as rest and digest. Not think about it like it's parasympathetic acting, but it has the same side of action, mechanism of action inside your body. You'll have meiosis, pinpoint pupils, and then out of it, you feel like sedated, you need to sleep, you need to rest inside your bed. Respiratory depression, and this is the most important side effect of this one, because if you have overdose of this, it will lead to death. Physical dependency, and this we all know why this is happening. Hypertension, because you have your blood pressure to be low, you have your vasodilation everywhere inside your body. Infrequency, meaning like constipation and urinary retention, and nausea, you lead to like nausea and vomiting, and mimesis. So this is morphine. It will help you to understand the side effect of opioids because it's important for you to understand it. And like some information more about here, meperidine is the least one to cause meiosis. That's why they ban the use of meperidine as tablets, because this has more frequency or more tendency for health worker to get used to use this stuff and maybe get dependency over this, because you cannot take it. Because if your patient is saying morphine, taking stuff like this, you can see this pinpoint papules. It's very, like, you can see it inside your patient face beside the other side effect happening for your patient. But for this one, meperidine has the least one of meiosis, so it can go undetected. So that's why they ban use it. It's only now IV. So here we speak about the not. He giving you mydriasis. Mydriasis meaning large opening of your eye to get more lights, and this happen in fight and flight, like acting like sympathetic system. It's not like sympathetic or parasympathetic. I'm trying to give you like a point of reference where you can collect stuff together. Management. Immediately after administration of inferior alveolar nerve block to start the root canal treatment on tooth 37. And for management, I would like you to think about it as clinical scenario inside your office where you're doing, and there is very important word here, say immediately, and this will tend to push you toward some thinking, some stuff you think about it. The patient complained of dizziness, nervousness, increased heart rate. Which of the following the most likely diagnosis? And then you might think, maybe my patient is getting LA toxicity. Maybe my patient is getting syncope. Maybe my patient have something to do with his heart because like increased heart rate. Maybe my patient is going to have MI, so you are confused here. So let's read option and then think again. LA toxicity, epinephrine action, syncope, cardiac arrhythmia. So let's read the question again and read whatever mentioned. He say immediately. So you might think about LA toxicity, not very common to be immediately, but it might happen if your patient has hepatic problem, if your patient is thinking like more freezing, there's a third or fourth LA carpule giving to him. And then syncope, and you know syncope, it has different clinical picture. Immediately meaning, yeah, you might think about it because like scenario here, immediately after inferior avar infiltration, inferior avar block, and your patient is going to do root canal treatment, so it might happen. But we know syncope has different clinical picture. It might have no increased heart rate, no nervousness maybe, but like dizziness and increased heart rate, it will tip you off from syncope. I think cardiac arrhythmia will have completely different picture. So we are now here between LA toxicity and epi reaction. So this is I'm trying to explain with you and think with you because I'm not here to give you the answer. I'm here to discuss a concept with you, how you think about management question. So let's go to textbook. Anesthesia. A common reaction to LA involves an anxious patient who become of concern about receiving a shot. So your patient is anxious, like, are you giving me needles today, doctors? Like, why are you giving me needles? So you can think about this one. Experience a psychogenic reaction that include hyperventilation, tachycardia, sweating, paleness, and syncope. So this is the action. It might happen for your patient while giving him LA. So this is how we think about it, and this is how I would suggest you to think about it. So you pile the emergency to a trigger, and then you go to differentiate between the emergency according to the wording in your question. True allergic reaction to LA amides used in this dentistry are rare. However, LA containing a vasoconstrictor that can cause epinephrine reaction, which is tachycardia, sweating, and paleness, which usually result from inadvertent intravenous injection. Meaning, like sometimes we're giving the inferior aortic nerve block, you might go very close to vein. When you go very close to a vein, maybe the solution is going rapid inside your bloodstream, leading to this epi reaction, which is tachycardia, sweating, and paleness. But excessive amount of anesthetic also can cause a toxic reaction, which include signs and symptoms associated with toxic reaction to local anesthesia are talkativeness, slurred speech, dizziness, disorientation, euphoria, and nausea, followed by muscle twitching or convulsion, mental respiratory depression, unconsciousness, coma, and cardiovascular collapse. So I want you to think about it steps and a scenario inside your mind so you can get to conclusion. Okay, the question here didn't mention any of those signs, so I cannot think about LA toxicity. He speak about only the first phase. We said maybe it's every reaction. But to get the complete knowledge here, how to deal with patient with LA toxicity. So we have three categories. So mild toxicity, your patient will have tachiness, anxiety, stuttered speech, and confusion. How to deal with him? You stop, monitor all vital signs, and observe in office for 1 hour. So you do nothing, you just speak with him. Moderate toxicity, when your patient giving more alarming signs like stuttering speech, like he cannot speak, nystagmus, tremors, headache, dizziness, blurred vision, or drowsiness. So now it's getting more serious. You let your patient in supine position, monitor vital signs, and you give him oxygen and observe in your office for 1 hour. But sadly, if it's not your day, your patient get to seizure, get to cardiac death arrhythmia, or arrest. So you get your patient in supine position. If seizure occur, you protect your patient from nearby object, and then suction content of oral cavity to make sure that he's not getting anything inside his abdomen. Have someone summon medical assistance, so you need to call 911, monitor all vital signs, you will give him oxygen, and start intravenous line to get to like dilute whatever inside his body. And you give him diazepam 5 to 10 milligrams slowly, or midazolam 2 to 6 milligram, and then institute basic life support if your patient getting to arrest and transport to emergency care facility. So this is a complete package of dealing with LA toxicity. You should know which stage you are in, and then depending on the stage, you are going to manage your patient. It's not like every patient with LA toxicity you are going to call 911 or give diazepam. It's a story building up, and you should know it and get the hint from the question to easily get the answer. So here we said immediately, but your patient here have only nervousness, increased heart rate, which is tachycardia and dizziness. So it's epi reaction. We cannot come to conclude a syncope or cardiac arrhythmia because we need more. And for IA toxicity, as you see, it starts with talkativeness and with coma and convulsion or maybe arrest. Next question from pharma. Which of the following is true regarding the management of patient who is receiving warfarin and a history of previous cerebrovascular accident? So we should go to the guideline. So discard the option. Before we read the option, I would like you to know the guideline, to know how we think about it, and then let's read option, and then you can come to conclusion. Okay. So first, before we speak about anything, let's speak about warfarin. And I would like confirm with you to know the other name, because I remember one of my friends, I told him, man, you should know the other name. Just like, oh, don't worry, they will never give me the other name. And the exam, they have a question starting with Cumaran. And he came out after the exam, like, what's this? I don't know this medication. Man, it's warfarin. Or Coumadin. The most widely used Coumarin in the United States is warfarin, stuff like this, is an oral anticoagulant that inhibits the biosynthesis of vitamin K dependent coagulation protein, which is factor 7, 9, 10, and 2. Like you can say it 1, 2, 7, 3. 1, 9, 7, 3, which is 10, 9, 7, 2. 10, 9, 7, 2. Warfarin is named after the patent holder, like his name here, and the warfarin is bound to albumin, metabolized through hydroxylation by the liver, and exerted in urine. I read this out loud because you might see question, warfarin is metabolized where? Warfarin is excreted where? So because I know this is like easy question, please do not miss them. Bind to which protein, which is albumin protein. And then we speak about PT, partial thrombin, is used to monitor warfarin therapy because it measures the 3 of the vitamin K dependent coagulant protein, which is factor 9, factor 10, and factor 2. And I would like to confirm here, it's not written here, but like I would like to confirm with you, the first factor to drop after giving your patient warfarin is this factor. I know it's like, as you see here, BT is particularly sensitive to factor 7, the deficiency. Therapeutic anticoagulation with warfarin takes 4 to 5 days. Okay, so we come to know now what is warfarin, and what it's used for, how it's working, and how it acts on your body, and which factor it will go through it, and which one it will be metabolized, and how the patient, your body getting rid of it. But why you are using warfarin? So we're using warfarin for a wide range of patients. We use it if patients have venous thrombosis before for high-risk surgery. We use prophylaxis. We use it to treat venous thrombosis. We use it to prevent systemic embolism, like patient with lung respiratory embolism from before, or our patient has history of cardiovascular accident. We used to do it, but it has 2 phases of acting. We're using warfarin to get INR to a specific level. Like warfarin, it's like anticoagulant, so it will lead your body to make your blood to be thinner. It's blood thinner in a basic term. So we have 2 categories. First, this at high risk, we're going to, this category of patient is at not very low high risk. So we are aiming to get their INR to be between 2 and 3, which you can see 2.5. But when our patient really at high risk, prevention of recurrent MI, treatment of thrombosis associated with anti-phlebitic antibodies, or your patient has mechanical prosthetic heart valve, so we are increasing our target to be between 2.5 to 3.5, so a target to be 3. Why I'm reading this? Because sometimes ask you a question, very simple question. Your patient is getting warfarin as a prophylaxis against venous thrombosis. So what's the level your patient is aiming to reach to? So it's 2.5, and this patient, it will be 3. So now you understand how it works and why we are using it. So let's speak about dental management. So here is like everything you need to know about dental management, but I think this is too much. So let's make zoom in so you can read it to get the conclusion. The risk for excessive bleeding after invasive dental procedures depends on the level of the patient INR. If INR is greater than 3.5, significant bleeding may occur after invasive dental and surgical procedures. So, in this case, you need to go to his medical doctor to ask him to speak about INR, how you can control. You are not to modify the dose for warfarin. It's not your job, and get rid of it. You just let the medical doctor deal with this. These procedures can be performed with little risk of significant bleeding if INR between 2 and 3.5. So we come to conclude, like dental surgical procedure, even if it's invasive, it's safe to be done if your patient INR between 2 to 3.5. But if in the INR between 3 and 3.5, which is included in this range, but your patient significant bleeding may occur with major oral surgery, and INR may have to be reduced to 3 or lower. So meaning if your patient is going to do Lefort surgery, if your patient to go to do surgery for TMJ, so the level of 3 to 3.5 is not good. It should be lower than 3. So to wrap it up for you, major surgeries like report stuff like this, it should be lower than 3. If like extensive surgical procedures, meaning like perio surgery, impaction for 2, you are going to remove 3/8 and 2/8 in same visit. So if his INR between 2 to 3.5, you can deal with them in a safe way. And let's read more, because when you read more, it's getting more for you. A dentist should consult with the patient physician to determine the level of anticoagulant being maintained with warfarin therapy. So you never are going to do surgery for patient taking warfarin before you consult. If invasive procedure or minor oral surgery are planned and the patient IN are between 2 to 3.5, no adjustment in the warfarin dose is indicated. But if INR is greater than 3.5, the dentist should request that the doses be reduced to allow INR to fall in the range between 2 and 3.5. And if major oral surgery, we speak about it to go to be less. If the dosage of warfarin is reduced by the patient physician, it will take 3 to 5 days for the desired reaction to occur. So it's not letting them go, coming back, you do surgery second day, at least 3 to 5 days. The reduction should be confirmed. You're not going, but doing by like conclusion, by INR, which before the dental or surgical procedure within should be scheduled within 2 days after confirmation of the reduction. Meaning, let's get by a timeline. Your patient came to you Monday. You told him no, go to your medical doctor. He did catch appointment with a medical doctor in a way to be in Friday. He did see his medical doctor and called the office back saying, okay, doctor adjusted the dose for warfarin. So you will ask him to take the new dose Saturday, Sunday, Monday, Tuesday, and then Wednesday he will go to lab to confirm the INR. After he's confirming the INR, you should book him after 2 days. So this is a timeline. The reduction should be confirmed by INR before the dental or surgical procedure, which should be scheduled within 2 days after confirmation of reduction. So if he did the test Friday, so you should max see him Sunday because it's within 2 days. If he did the test Friday and he'd miss appointment Sunday and he came after 5 days, so this test is invalid. You should make a new test. So the maximum is 2 days, and they would recommend usually to be the same day. In the morning, you do the INR and then come to you. After it has been determined by the dentist that there are no significant complications, the patient physician should be contacted to resume the patient usual warfarin dosage. I know I speak a lot about this one because this is confusing, and when I read the option now, it will be more confusing. So you need to understand the concept and how does it work. Timing is very important because sometimes they ask about timing and it's so easy, but like you get confused. Non-surgical procedures should only be performed after consultation with a physician, INR below 2.5. We say consultation is good, but like it's non-surgical and he give you here should. So this option is not correct. Minor surgical procedure can be performed after consultation, correct, with the physician and INR below 3.5. So he said minor 3.5, amazing. Major should be performed after consultation, correct, and INR below 3.5, no, we said major is different number. Minor and major surgical procedures should be avoided until the patient is no longer taking warfarin. You cannot tell medical doctor, ask him, please stop warfarin, because he's not giving warfarin for his patient, because like he need to take this warfarin because he's high risk. As you just see, the type of patient taking this medication are really at high risk. Previous history of MI, previous history of embolism, deep venous thrombosis. So it's high risk for your patient to stop warfarin at all. You should just monitor and adjust the dose to get the different INR and then proceed and then go back to medical doctor to go back to his dose. I hope this will be beneficial for you because I'm trying to get the whole concept. Last question from pathology. We cannot do newsletter without pathology. Like it's happening in the exam a lot. So let's get one question from this topic. Necrotizing sialometaplasia is a pre-malignant condition presents as a painful ulcer in the palate, does not require surgical excision, all of the above. So let's speak about this one first, and then you come to conclude what is the answer here. So, necrotizing sialometaplasia is a benign self-healing lesion on the accessory palatal salivary gland that can be confused clinically and histopathologically with carcinoma. So what happened here? Let me explain to you. So, your patient come to your office, do extraction for 1/4, and you are a very good dentist trying to give your patient excellent service, not to feel like the freezing you are going to give to him. So you get your back of the mirror and against the palate of your patient, and then you push, not for him to feel the prick of the injection. And then for your padlock, for just out of your padlock, This mirror come to contact with orifice of minor salivary gland, or come to contact with a duct or minor salivary gland, which lead to this canal to be torn. So what's happening here? After this patient goes home, he will start to feel a swelling in his palate, which is extremely painful. Why is painful? Because the salivary gland is trying to do its job to get the saliva and get the saliva out inside the patient mouth, but the canal is torn. So the saliva will get inside the salivary gland, leading to swelling. So let's read. After trauma and present as rapidly growing swelling on the lateral aspect of the hard palate, leading this infraction, like meaning like when the saliva is trapped inside the salivary gland as a result of vasoconstriction and ischemia caused by trauma or dental injection, appear causative. Then what's happening for your patient? It will start as a small painless nodule that enlarge and cause pain. Within a few weeks, it ulcerate and the pain diminishes. So it will be painful swelling, painless ulcer. So what happened in this? After the swelling getting bigger, so the swelling will get to rupture. When it ruptures, saliva is go outside, so your minor salivary gland tend to get the saliva outside, so there is no need for your patient to feel pain because the saliva is going outside. So the size of the swelling varies, and the growth to diameter of 2 cm is possible. A deep central ulcer with gray pseudomembranes is characteristics. So your patient come to your office, you look inside your patient mouth, you see ulcer with a gray pseudomembrane, and your patient will speak about it was painful and now it's not painful. And here come the confusion with like carcinoma, because this is a typical picture, clinical picture for like squamous cell carcinoma and carcinoma inside the palate to be ulcer, and this with pseudomembrane over it. The ulcer is irregular and papillary. The border is often rolled, like typical for squamous cell carcinoma. Healing occur on its own over 4 to 8 weeks or after a biopsy. And here, let's stop 1 minute. For your patient, when he come to you, so you ask him questions. If he'll tell you, I have a history of trauma because of you, of an extraction, or maybe something go inside his mouth, and it was a painful swelling, so you do nothing for him. So as we said, it's self-healing. It will solve by its own 4 to 8 weeks. But if your patient didn't give you anything, any history about this one, so you should do a biopsy because you cannot differentiate between those. So you get a biopsy. Biopsy is recommended to rule out similar appearing lesions such as salivary gland tumor and malignant lymphomas. So this is the story of sialometaplasia, and this is how it looks. So your patient come for you, ulcer, grayish membrane, rolled out border, and you think about like this is squamous cell carcinoma. So you should get to history for your patient, or to confirm it, you do a biopsy. But that bottom line, after biopsy, you confirm it's sialometaplasia, you do nothing because it's self-healing within 4 to 8 weeks. You let your patient go home, make sure he's happy, and not to like get your patient to do more surgery for this. Pre-malignant condition, no, it's self-healing. Present as painful ulcer in the palate, no, painful swelling, and we speak about the mechanism. Does not require surgical excision. Yes, does not require surgical excision. Once you reach conclusion, it's biopsy just to reach a conclusion. When you know it is sialometaplasia, you do nothing. Let it heal by itself and not all of the above. Okay, that was all for today newsletter. As usual, every day we'll have questions in our community. By the weekend, we'll post this video. Feel free to give me your question about it and give me your feedback. Feel free to share it and download the PDF. And as usual, see you next Sunday. Have a good day.